All right, guys, we're back with the Ask the Doc series, and we're gonna get started right away with the first question. Dr. Ren, love the series you're doing. I have a quick question. I was hoping you could press on for a future episode. I'm a 36-year-old man and recently decided to have my testosterone levels checked after noticing some of the low T symptoms Dr. Ren has been describing. Lower libido, lack of morning erections, overall diminished joie de vivre. That's your words. It turned out that my total test was 727 with a lab normal range of 2 to 800. I'm curious if the doc thinks it's worth digging a little deeper and check out free T and estradiol, or if I should just move on and be happy with my level and naturally where they are at. Thank you, Tommy.
Well, to me, part of that's an easy question. If you're not happy, don't move on and pretend like you're happy. I would definitely investigate more because it's like a hypertension diagnosis. You don't make a diagnosis based upon just one number. There could be lab error. We don't know what the free T is, the free testosterone, which is where the rubber meets the pavement. That's what is actually active. So if he's got a high sex hormone binding globulin, then maybe his free T is low despite what would be a healthy testosterone level of in the 700s, he said, right?
Yeah.
The other thing he mentioned too is that his estrogen wasn't checked, and if the estrogen is high, that can put a damper on how you're feeling too.
Oh.
So it's worth investigating for sure. Going another round of tests, make sure you include estradiol, and I mean, there's an expression I wear out in my practice that if you see a hoof print, you look for a horse before you look for a zebra. But certainly, if we find out that his testosterone levels, including his free T, is high, well, then you might want to look for something else that's going on that might be just as significant or more. I mean, how can you say more? I mean, if he's not happy, if he's not feeling well, then you want to get to the bottom of it. But it also goes back to what I always say too, and I think most doctors would agree, you treat people, you don't treat numbers. So certainly if you're feeling the symptoms he describes, you want to look into it and figure out what's going on. But on the surface anyway, yeah, with a nice, what he said, 700 and some nanograms per deciliter, that's a healthy number. These days, you would think a 36-year-old would have a good, healthy number like that, but I see people all the time that age or lower or younger with lower testosterone levels because of all the things we've mentioned in prior videos about stress and other factors. But everyone's different too, and somebody might have grown up with an 1100 nanograms per deciliter. Again, I'm using total because that's the only number we have, but a higher level, and that much of a drop for him is significant, whereas somebody like me might be jumping for joy with a 700 level, you know. So that's the other thing you have to take into consideration.
It's all relative.
It's all relative, and we have a standard of care. I think we've also mentioned before, Dr. Abraham Morgenthaler, who's associated with Harvard, wrote a book, Testosterone for Life, and used, I don't want to say arbitrarily, but my point is that, again, how can you just draw one line? But as a general guideline, 450 nanograms per deciliter as a marker or a line in the sand as to what's considered hypogonadal, below obviously or not. But I think he also makes the point. This lab that this gentleman mentions, 2 to 800, that's a narrower range than most. I've seen 250 to 1200 roughly on other labs, and of course, people may not necessarily know this, but that's a huge swing. That's a significant range, in other words.
Yeah.
And again, it just goes back to the relativity of it all. And the other thing with this treatment is it's hard to go wrong. In other words, if you exhaust all the other avenues as to why he's not feeling well, the risks of treatment are low. I've mentioned before, if someone we're saying, you know, I'm coming in at, you know, a free T that's marginal, free and total T that's marginal. Let's say for this example, it's instead of 450, it's 550, but he's got the symptoms. Well, what's the risk of giving testosterone replacement therapy a trial, especially if, you know, we've mentioned before too, 35 is roughly by definition where we know the levels start to drop off based upon studies. So if this is a 36-year-old male, what are the risks of going through a trial of replacement therapy if we can't really find any other reason
There's more
for
to
what's
gain than to
going on?
lose.
Yeah. In his case, you might want to look at, and this is maybe more of an extensive answer than he wants, but I mean, you can start to break that down. The joie de vivre. There's neurotransmitters that can make you feel good or not. Dopamine's a feel-good hormone. You know, under stress, or if he's producing too much prolactin, he might not be making enough dopamine. Although if his prolactin were high, his testosterone probably wouldn't be high, right? But there's neurotransmitters that are involved. Erections. Maybe he's not making that much nitric oxide. We haven't even, because we don't have the information, but what's his protein intake like? Is he getting sufficient amino acids to even make nitric oxide? So I know I'm getting off too far on a tangent, but we'd want to investigate more for the reasons I mentioned at the beginning. That, of course, if you're not feeling good, let's figure out why.
Yeah, that's right. Good. Thank you, Doc. Okay, next one. Great series, Dr. Rand. Thanks for putting all this together. There isn't anything like it out there, and it's very much appreciated. See, you're getting some props today.
Very much my pleasure. How's that?
That's great. Can you ask the doc to talk a little more about Aromatase and HCG on TRT? I've been doing some research, and I'm a little confused. Some say never start TRT with an AI, and if estrogen gets out of hand, just lower the T dose. They claim estrogen is the higher range. Is better in a higher range is better for libido, bone health, etc. That Aromatase is hard to dial in and long-term risky, and if you are going to use it, stick to no more than 1 milligram per week. HCG comes up a lot too. I've heard that it's necessary even if you don't want children, since the tests produce other important hormone like pregnenolone. I'd love to get a doc's take on all this. Thank you.
You might have to help me review parts of that question.
Yeah, that's a lot, right?
Multifaceted, yeah.
So
the idea of not taking, doesn't have to be an AI necessarily, an aromatase inhibitor necessarily, but something to block the conversion to estrogen or block estrogen receptors. That's I don't want to say unheard of, but that's, as I say to most people, the fly in the ointment in TRT, testosterone replacement therapy, is estrogen, or sometimes what testosterone can get converted into also dihydrotestosterone, particularly for women, but also for men if they have male pattern baldness in their genes. But I just, after I don't know how many years, just came across one person out of I don't know how many people I've treated, okay, one person we find without any aromatase inhibitor. And by the way, that's what I choose to use, just because to me it seems like a much more elegant way of doing things, just to block the conversion of testosterone into estrogen to begin with. So you spare the very thing that you want on board, and then you don't even make too much estrogen. I'm not sure we've identified all of the estrogen receptors, and certain estrogen blockers block differently. Tamoxifen blocks differently than Clomid does, because it'll block in certain areas. Clomid won't block estrogen receptors in the liver, for example, but will elsewhere. So you get into things we don't necessarily want to get into when we veer off from aromatase inhibitors. But I would say quite the opposite to what he's saying. If you're going to take testosterone, you almost invariably better be taking an aromatase inhibitor or something to block that estrogen buildup, because estrogen is, as I said, the fly in the ointment that causes the side effects. Water retention, and I'm talking about in excess. We do need some, and we talked about this before.
Yes,
we need some for brain health, cardiovascular health, and joint health. But in excess, it makes you hold water, tends to make you retain fat, tends to make us moody and irascible. And if those aren't enough reasons, it also activates the genes that we all have as men for prostate cancer. So quite the opposite. Get on some form of estrogen protection, we'll call it, when you're doing TRT. To reduce the dose makes some sense depending upon how much you're taking to begin with and what effects you're getting. Obviously, you're taking TRT to get to control the symptoms and the signs of aging. If you reduce the dose and the trade-off is, okay, now my estrogen's fine, but I don't feel any benefit anymore, then what's the point? And we've known since the 50s that, and again, I'm using the total numbers now, but just to make the point, back then they were using total numbers, 800 nanograms per deciliter or above testosterone is necessary, or you won't find clinical benefit to it. So the reduction of testosterone doesn't make too much sense.
Yeah.
As far as starting it, start it whenever you start testosterone therapy. Higher levels, we do have an association between higher levels of estrogen and, for example, a higher HDL. I don't want to get into what we're finding and have known for quite a while about cholesterol and plaque buildup. But there are other reasons to be concerned with cholesterol, but that's not necessarily something we need to focus on, is my point. Bone density, that's a good point. However, at what cost? The main factor with bone density is, are you doing weight-bearing exercise? So get off the couch. Are you taking calcium? Yeah, it's necessary, but calcium's not going to make the difference. It's just going to make you constipated if you're working out, or you're not working out, but you're taking calcium. Ditto vitamin D3. You have to have those things, and estrogen can help you with that, but testosterone does too.
Right.
And again, you need just enough, not excess.
Right.
As far as
the
HCG goes, he made reference to pregnenolone or progesterone. Pregnenolone, right?
Yeah, pregnenolone.
HCG is going to activate the Leydig cells in the testicles, and just without getting overly complicated, although I know most of our viewers know about what I'm talking, but HCG is an analog. It mimics luteinizing hormone, which is what the pituitary sends to activate the Leydig cells in the testicles, and those cells, the Leydig cells, produce testosterone, not pregnenolone. The testicles do produce some pregnenolone, but most of it's made in the adrenal glands. So the HCG is not really going to do much, unless maybe indirectly, if you follow me, because that's part of the cascade of hormones that starts with cholesterol. By refilling the gap that you had with testosterone, maybe some pregnenolone won't be converted into testosterone. That's maybe kind of a reach, but no, I don't think that his concern should be with pregnenolone when it comes to HCG. Simply, I recommend HCG for really a couple reasons. One, cosmetic, for guys that are on hormone replacement therapy and you get some testicular atrophy because the Leydig cells senesce or go to sleep. I think the testicles are made up of roughly 20% Leydig cells, so you'll have some atrophy, sometimes significant, which is to some unappealing. And then for fertility, the Sertoli cells have to have endogenous nearby testosterone to work. The Sertoli cells are the ones that produce sperm. So we want to keep the Leydig cells functional and make it easier should someone who's, for example, like this 36-year-old gentleman we were talking about earlier, may not have had kids yet, but has he didn't have low T, but somebody who does have low T established, but still wants to have kids, it makes it easier to either maintain fertility or restore fertility should they lose it, once they stop TRT, just to have the child. So
is that the only two reasons you recommend people to take that? Because I was actually going to ask you that question. I was going to ask you, a lot of time bodybuilders, I'm not talking about TRT people, bodybuilders will, at the end of the big cycle or at the end of the cycle after a competition, will go on HCG and other things to kind of kick back their tests level, the testicles.
Which makes sense. And I'll tell guys that are planning on going off for whatever reason, again, whether it's fertility or not, to start using HCG before you stop using testosterone, because the testicles are kind of like diesel engines, I call it. They take a while to bring the Leydig cells back online, as opposed to the pituitary, which is more like a gas-powered engine. Hope this analogy works for people.
No,
it starts up right away. So you get the testicles up and functional, you withdraw the HCG, and as soon as the test levels start to drop again, the pituitary will recognize it and send luteinizing hormone, and the testicles are functional again.
I see.
And of course, a lot of this depends upon how long you've been on TRT, etc. But
would you have them do both at any point? Would you have them do TRT or do a cycle and take HCG as well at the same time?
well, again, for guys that are on TRT, it's important if you want to preserve fertility, in my opinion, and of course for cosmetic reasons, either one,
Yeah.
to use HCG, but you want to punctuate it with a period of rest. And there's nothing scientific necessarily about this, but I'll say, hey, take 30 days off, just so the Leydig cells don't become desensitized to the effect of HCG.
I see.
So you've always got that in your quiver, as a source, because I don't know, I mean, there are other ways, but they're more involved to stimulate the Leydig cells and more costly. HCG is a relatively cheap and easy way to do it, although I say easy, it's a pain in the neck.
Yeah.
Relative to one shot of testosterone each week. Generally speaking, I'll recommend anywhere from 250 to 500 IU of HCG either every other day to as much as every day, depending upon a lot of factors. But again, to avoid desensitization of the Leydig cells, no more than 500 IU a day. Now, I know a lot of docs who are involved in fertility may use what amounts to more than 500 IU a day, but remember, they're doing it typically temporarily.
Yeah.
To get
a boost.
Yeah, to get to a goal of, hey, let's have this child, and then they'll stop it. So this tends to be, at least in my practice, using TRT, a more regular thing. So you never really want to lose that, as I said, that arrow in the quiver.
Gotcha.
So you go on and off to preserve.
Didn't you also tell me in the past that if you did HCG the day before you did your shot at TRT, it was actually avoiding sort of like it was giving you a longer curve, or the test working, or no, was that wrong? I don't remember.
Wasn't me.
Time ago.
I don't think. But some docs will use a combination of HCG and testosterone replacement therapy to get to a certain level. I found it doesn't work as well clinically, and it's, again, a pain in the neck. Obviously, there's some people that say, look, I could care less. I'm 60 years old. I don't care about fertility.
Yeah.
I'm happily married, let's say, and my wife and I both could care less about the cosmetics of my testicles. Gotcha. And why do I want to, use HCG 3 or 4 times a week? So there are factors involved, but again, some docs will recommend a combination. I guess the theory being that if we can preserve some of your own endogenous function, it's better. My view of that is, without sounding like I'm saying that that's the wrong way, it's just, preserving what? If you've come to me for replacement therapy, obviously your own endogenous production is insufficient to begin with.
Right.
And it's only going to get worse.
Right.
And to preserve it, I don't know, why not just go ahead and replace it and do it with an injection once a week and move on. But we may find that's not the best way, because we might find that with a combination of HCG, aside from cosmetics and fertility, that there are other benefits to it. I just haven't seen them uncovered in studies yet.
Gotcha. That was a good question.